Good evening, Dr. Phil here. Today we'll be discussing on magnesium. Introduction. Magnesium is the fourth most abundant cation in the body. It is the second most important intracellular cation after potassium. The average size adult has about 24 grams or 1 mole of magnesium. 39% is located within the cells and 1% located in the ECF. Magnesium is present mainly in bone, over 50%, and skeletal muscle, 20%. The remainder is found in the heart, liver, and other organs. One half of magnesium ions are bound to plasma proteins, and the rest are free. Daily magnesium requirement is about 0.1 to 0.2 millimole per kg per day. Magnesium is essential for at least 300 enzyme systems. Magnesium is a cofactor for many enzyme systems including myocardial sodium-potassium ATPase and all those involving ATP synthesis and hydrolysis. Magnesium is essential for production and functioning of ATP, biosynthesis of DNA, RNA and proteins, regulation of most cellular functions, regulation of intracellular calcium and potassium, and the activity of neurons, myocardial and skeletal muscle fibers, myocardial conduction system, vasomotor tone, hormone receptor binding, etc. Regulation of magnesium balance is mainly by the kidneys. Magnesium absorption occurs in the GI tract. Free magnesium passes through the filtration membranes of the kidney to enter the filtrate. About 85 to 90% of those ions are reabsorbed from the filtrate. Of the magnesium reabsorbed, most are reabsorbed by the loop of Henle. The remainder is reabsorbed by the proximal convoluted tubule, distal convoluted tubule, and collecting duct. Only about 10 to 15% enter the urine. When there is a rise in blood magnesium levels, this increases the magnesium levels in the filtrate, and this exceeds the kidney's capacity to reabsorb magnesium from the filtrate. Magnesium is thus not reabsorbed from the filtrate, and magnesium enters the urine. There is increased magnesium loss in the urine, and this decreases blood magnesium levels. When there is a decrease in blood magnesium levels, there is reduced magnesium levels in the filtrate. Thus, the kidneys reabsorb most of the magnesium from the filtrate. Less magnesium enters the urine and blood magnesium level increases. The exact mechanism for control of magnesium reabsorption in the kidneys is not clear. The kidney's capacity to reabsorb magnesium is limited. Mechanism of action of magnesium. Magnesium acts as a natural calcium antagonist. This non-competitive inhibition mediates many of magnesium's effects. Increased extracellular magnesium results in increased intracellular magnesium, and this inhibits calcium influx through voltage-dependent calcium channels. Magnesium competes with calcium for binding sites on the sarcoplasmic reticulum, and this inhibits calcium release. Non-competitive inhibition of phospholipase C-mediated calcium release occurs. Magnesium also works by physiological NMDA receptor antagonism. Magnesium inhibits presynaptic release of acetylcholine, sodium-potassium pumps, and post-junctional potentials. Magnesium has anti-adrenergic actions. Magnesium reduces catecholamine release and reduces the release of adrenergic hormones at all synaptic junctions. Actions of magnesium. Central nervous system and peripheral nervous system. Magnesium penetrates the blood-brain barrier poorly, but is still able to mediate central effects. Magnesium stabilizes excitable membranes, resulting in neuronal and myocardial membrane stabilization. Magnesium interferes with the release of neurotransmitters at all synaptic junctions. This produces CNS depression and sedation. Magnesium enhances the effects of other CNS depressants. Magnesium produces cerebral vasodilation and anticonvulsant effects. The onset via IV route is immediate, and the onset via IM route takes 1 hour for its anticonvulsant actions. Duration of action is, for the IV route, 30 minutes, for the IM route, 3 to 4 hours. Magnesium reduces deep tendon reflexes. Deep tendon reflexes are absent at a magnesium blood level of around 8 to 10 millimoles per liter. Magnesium blocks peripheral neuromuscular transmission. Magnesium reduces the onset time and dose requirements of non-depolarizing muscle relaxants. However, magnesium does not potentiate the actions of depolarizing muscle relaxants. Dose reductions of CNS depressants and non-depolarizing relaxants of up to 50% should be considered in the presence of magnesium sulfate treatment or hypermagnesemia. Cardiovascular effects. Magnesium antagonizes atrial L and T-type calcium channels and prolongs both atrial refractory period and conduction. Reduced cardiac conduction is opposed partly by the vagolytic action of magnesium. Magnesium inhibits potassium entry and suppresses ventricular after depolarizations. Magnesium produces negative inotropy and sympathetic block and the inhibition of catecholamine release. There is reduced vascular tone via peripheral vasodilation, mediated at least partly by endothelial nitric oxide pathway. Respiratory effects include reduced respiratory muscle strength, reduced bronchomotor tone. Magnesium has no effect on respiratory drive. Renal effects include vasodilation and promotion of diuresis. GI effects. Oral magnesium laxatives causes osmotic retention of fluid in the colon. This produces distension and increased peristaltic activity, which subsequently results in bowel evacuation. In the uterus, magnesium produces tocolysis. Magnesium crosses the placenta and may exert effects in the neonate, such as hypotonia and apnea. Hematology. Magnesium prolongs the clotting time of whole blood. Magnesium reduces thromboxane A2 synthesis and inhibits thrombin-induced platelet aggregation. Pharmacokinetics of magnesium when administered IV. Magnesium is redistributed rapidly into bone 50% and intracellular fluid 45%. Protein binding is 30%. Half-life is less than 1 hour. There are no active metabolites. Excretion of magnesium is via the urine. Measurement of magnesium levels in the body. Magnesium levels may be measured in the serum or the urine. Serum magnesium levels is favored over plasma for magnesium assays because the anticoagulant used for plasma samples can be contaminated with citrate or anions that bind magnesium. Serum magnesium level is an insensitive marker of magnesium depletion. Only a minor fraction, 0.3%, of total body magnesium is located in the plasma. Monitoring plasma magnesium levels provides little information about total body magnesium. Plasma magnesium can be normal although there is total body magnesium depletion. Since total amount of magnesium in the plasma is small, differences between ionized and bound magnesium may not be large enough to be clinically relevant. Normal levels for total magnesium is 0.7 to 1 millimoles per liter. This is the standard assay for magnesium and includes all plasma fractions. Normal levels for ionized magnesium is 0.4 to 0.6 millimoles per liter. 67% of magnesium in the plasma is ionized. The rest is bound to plasma proteins or chelated with divalent anions such as phosphate and sulfate. Urinary magnesium. Urinary magnesium excretion is dependent on magnesium intake. When magnesium intake reduces, kidneys conserve magnesium and there is reduced urinary magnesium. Urinary magnesium levels or urinary magnesium excretion in response to a magnesium load is more reliable than serum magnesium levels in detecting magnesium depletion. Normal levels of urinary magnesium is 2.5 to 7.5 millimoles over 24 hours. Renal magnesium retention test. This is indicated for suspected magnesium deficiency when serum magnesium is normal, or to identify the endpoint of magnesium replacement therapy. It is contraindicated in renal failure or ongoing renal magnesium wasting. The protocol is to add 6 grams of magnesium sulfate to 250 ml of normal saline and infuse IV over 1 hour and collect urine for 24 hours, beginning at the onset of magnesium IV infusion. If the urinary magnesium excretion in 24 hours is less than 12 millimoles, this is evidence of magnesium depletion. If it exceeds 19 millimoles, this is evidence against magnesium depletion. Clinical uses of magnesium. Magnesium is used in preeclampsia and eclampsia to prevent eclamptic convulsions. Magnesium reduces cerebral vasospasm seen in this condition. Magnesium sulfate is superior to diazepam and phenytoin in preventing primary eclampsia as well as preventing recurrence of seizure. Magnesium sulfate reduces CNS excitability and produces systemic vasodilation, which reduces systemic vascular resistance and produces hypotension. Although magnesium reduces blood pressure as a result of vasodilation, it is not used in severe preeclampsia for this purpose, but for the prevention and treatment of eclamptic seizures. Labetalol, nifedipine, and hydralazine are more commonly used to lower blood pressure in preeclampsia. In the MACP trial, published in Lancet in 2002, 10,000 women with preeclampsia were randomized to receive magnesium sulfate before or during labor or after giving birth. Magnesium has been shown to reduce seizures by more than half. Treatment was also safe in this setting without any excess of serious morbidity. Total maternal mortality was lower in treated women, although this did not achieve statistical significance. The IV dose for loading dose is 4 grams over 5 to 15 minutes. The infusion dose is 1 gram per hour for 24 hours. The therapeutic blood magnesium sulfate level is 2 to 3.5 millimoles per liter. Asthma. Magnesium sulfate is a bronchodilator that can be effective in treating severe refractory asthma. The dose is 2 grams IV over 20 minutes. Acute arrhythmias. Magnesium sulfate is used in the treatment of ventricular tachyarrhythmias, torsade points associated with a long QT interval. This is a type of ventricular tachycardia occasionally induced by class 1A or class 3 antiarrhythmic drugs, which prolong the QT interval. Magnesium sulfate is also used in the treatment of arrhythmias induced by adrenaline, digoxin, local anesthetics, hypokalemia, hypomagnesemia. Magnesium sulfate is also used to treat multifocal atrial tachycardia. In this type of arrhythmia, there is irregular SVT with 3 or more P-wave morphologies and irregular atrial activation pattern. Risk factors for MAT includes elderly, chronic lung disease, pulmonary hypertension, magnesium and phosphate depletion, theophylline toxicity, and coronary artery disease. Magnesium sulfate has 88% success rate in converting MAT to sinus rhythm. Alternative treatment for MAT includes metoprolol and verapamil. The typical dose for magnesium sulfate in the treatment of acute arrhythmias is 2 grams infused over 10 to 15 minutes, followed by IVI 72 millimoles over 24 hours. Hypomagnesemia. Hypomagnesemia is reported in as many as 65% of ICU patients, and total body magnesium depletion is even higher. Causes include loop diuretics and thiazides. These diuretics inhibit sodium reabsorption, and this interferes with magnesium reabsorption. Magnesium depletion is not caused by potassium-sparing diuretics. Nutritional deficiency can cause hypomagnesemia. Failure to supply adequate intake occurs in conditions such as malabsorption and critical illness. Other drugs may cause hypomagnesemia such as aminoglycosides, amphotericin, pentamidine, digoxin, cisplatin, cyclosporin, PPIs, adrenaline, etc. Diabetes mellitus can cause hypomagnesemia via glycosuria-induced urinary magnesium losses. Insulin treatment induces movement of magnesium into cells. In acute MI, there is intracellular shift of magnesium from excess catecholamines. In chronic alcohol intake, there is malnutrition and chronic diarrhea, and this produces magnesium depletion. Secretory diarrhea contributes to hypomagnesemia as secretions from the lower GI tract are richer in magnesium than the upper GI secretions. Other causes of hypomagnesemia includes acute pancreatitis, subarachnoid hemorrhage, and renal tubular dysfunction. Clinical features of hypomagnesemia includes confusion, tremors, irritability, weakness, muscle twitching, tetany, generalized seizures, and reactive CNS magnesium deficiency, which includes ataxia, slurred speech, metabolic acidosis, excessive salivation, diffuse muscle spasms, seizures, prolonged obtundation, and is triggered by loud noises and body contact. Hypomagnesemia can cause arrhythmias such as prolonged QT, torsade points, and magnesium deficiency promotes digoxin cardiotoxicity. Digitalis and magnesium deficiency both inhibit sodium-potassium exchange pump on cell membranes. IV magnesium can suppress digoxin-induced arrhythmias even when serum magnesium is normal. Hypomagnesemia is usually accompanied by other electrolyte abnormalities such as hypokalemia, hypocalcemia, hypophosphatemia, and hyponatremia. Magnesium depletion enhances renal potassium excretion. Magnesium repletion is necessary before hypokalemia can be corrected. Magnesium depletion produces impaired parathyroid hormone release and impaired end organ response to PTH, and this produces hypocalcemia. Phosphate depletion increases renal magnesium excretion. Reduced renal sodium reabsorption reduces renal magnesium reabsorption. Regarding the diagnosis, kindly refer to the magnesium measurement section discussed previously. Treatment of hypomagnesemia is with magnesium replacement. IV magnesium is preferred over oral magnesium preparations for magnesium replacement, as intestinal absorption of magnesium is erratic. Regarding IV magnesium sulfate, preparations includes 50% or 12.5%. 1 gram of magnesium sulfate equals 4 millimoles of elemental magnesium. Concentrations of less than 20% are suitable for peripheral IV administration. 50% magnesium sulfate has high osmolarity of 4000 milliosmol per liter and must be diluted to 10 to 20% with normal saline for IV use. Examples of oral magnesium tablets includes magnesium chloride, magnesium oxide, and magnesium gluconate. For mild asymptomatic hypomagnesemia, replace with 0.5 millimoles per kg for the first 24 hours, followed by 0.25 millimoles per kg daily for the next 3 to 5 days. For moderate hypomagnesemia, which is serum magnesium of less than 0.5 millimoles per liter, with or without other electrolyte imbalances, the dose is IV magnesium sulfate 6 grams over 3 hours, followed by 5 grams over the next 6 hours, and 5 grams every 12 hours for the next 5 days. For life-threatening hypomagnesemia, which is hypomagnesemia accompanied by serious cardiac arrhythmias or generalized seizures, the treatment is IV magnesium sulfate 2 grams over 2 to 5 minutes, followed by 5 grams over the next 6 hours, and 5 grams every 12 hours for the next 5 days. Cautions with magnesium replacement: avoid rapid IV infusion, which may cause respiratory or cardiac arrest. Thus, some authors recommend 5 grams magnesium sulfate over 1 hour instead of 2 grams over 2 to 5 minutes. Avoid IM injections as this increases the risk of abscess formation. For patients with renal insufficiency, no more than 50% of the magnesium in the standard replacement protocol should be administered, and monitor serum magnesium carefully. Magnesium is an analgesic. The analgesic effects of magnesium is via NMDA receptor antagonism. Magnesium sulfate has been used as epidural and subarachnoid adjunct to local anesthetics for post-operative analgesia and as an opioid-sparing IV analgesic. Magnesium has been used as a tocolytic to stop preterm labor, with a loading dose of 4 to 6 grams magnesium sulfate IV over 20 minutes, with a maintenance dose of 2 to 4 grams per hour IV for 12 to 24 hours as tolerated after contraction ceases. Do not exceed 5 to 7 days of continuous treatment. Long treatment duration may lead to hypocalcemia in the developing fetus, resulting in neonates with skeletal abnormalities related to osteopenia. Magnesium is used in the treatment of tetanus. Magnesium sulfate infusion is the primary treatment for muscle spasms and autonomic instability caused by tetanus. Magnesium sulfate can be used to control status epilepticus. In subarachnoid hemorrhage, magnesium sulfate prevents cerebral vasospasm. Magnesium has been used as an antacid. Magnesium trisilicate is a particulate antacid. It has been used to increase gastric pH preoperatively in patients at risk from aspiration of gastric contents, but may itself cause pneumonitis if inhaled. Sodium citrate, a non-particulate antacid, is thought to be less harmful than magnesium trisilicate if inhaled. Magnesium trisilicate has been used to reduce peptic ulceration in the ICU, for example, by hourly nasogastric administration to keep gastric pH above 3 to 4. Magnesium is used as a laxative to treat constipation. Magnesium has been used in the perioperative management of pheochromocytoma. Contraindications for magnesium includes hypermagnesemia, hypocalcemia, heart block, myocardial damage, renal impairment, oliguria, hypersensitivity, and diabetic coma. Use with extreme caution in myasthenia gravis or other neuromuscular disease. Magnesium accumulates in renal failure. Reduce the dose and infusion rate Do not exceed 20 grams of magnesium over 48 hours in severe renal impairment. Employ closer monitoring for signs of toxicity. Magnesium is removed by renal replacement therapy. Hypermagnesemia. Causes include iatrogenic, such as in magnesium sulfate overdose, hemolysis. There's high magnesium levels in RBCs. Serum magnesium may increase by 0.05 millimoles per liter for every 250 ml of RBCs lysed. Renal insufficiency can cause hypermagnesemia. Renal excretion of magnesium reduces when creatinine clearance is less than 30 ml per minute. Other causes of hypermagnesemia include diabetic ketoacidosis, adrenal insufficiency, hyperparathyroidism, and lithium intoxication. Clinical features. When the blood level of magnesium is more than 4 millimoles per liter, there is nausea, vomiting, somnolence, double vision, hyporeflexia, and slurred speech. When it exceeds 6 millimoles per liter, there is muscle weakness, paralysis, respiratory depression or arrest, bradycardia, arrhythmias, and hypotension. When magnesium levels increases more than 10 millimoles per liter, there is respiratory paralysis, complete SA node and AV block, and cardiac arrest. Monitoring during magnesium sulfate therapy. Monitor for sedation, such as by using the sedation score. Monitor for respiratory depression, hyporeflexia, urine output, magnesium plasma concentrations, ECG, and renal function. Options for treatment of severe hypermagnesemia includes IV calcium gluconate 1 gram. This produces transient treatment effects. Aggressive volume infusion with diuretics such as furosemide, if fluids are permissible and some renal function is preserved. Another option to remove magnesium is via hemodialysis. These are my references. Thank you.